So I was quite puzzled when Dr. Satyajit showed me this topic 2 weeks back, and suddenly preparing for complications arising to the COVID. But finally, I managed. Managed, and all the surgeries, what is being shown are actual complications of delay in pediatric cataract surgery. And the most importantly, the issues that we faced was delayed surgery, delay resurgery, and leading to dense stimulus deprivation amblyopia. And as we are all aware that delay in pediatric cataract surgery leads to a permanent vision loss, and the more every day we are delaying, it is leading to some permanent damage. And here we are talking of a situation in which surgeries got delayed for months together. And then I went back to my library and saw what all damage was done during this period. And many of the patients came with loose sutures because most of the pediatric cataract surgeries have suture in the main port, and that leading to infection and local inflammation. Complications like visual axis opacification after the surgery. Many of these children require resurgery, and visual axis opacification after the surgery was missed for months together, and that led to the stimulus deprivation amblyopia. Second eye surgery was delayed. One eye has got operated, other eye not operated. One case needed pupilloplasty due to post-op inflammation, that got delayed. And definitely the amblyopia treatment got delayed in many of them who were operated, and the parents were not. Many good thing is that many of them contacted us and asked us that patching was going on, what should we do? We are not able to come. So those parents could be directed and advised properly that you continue the patching, and whenever you can come, please come. But a large proportion of those didn't contact us and stopped patching in between, and that led us going maybe 5 steps backwards after moving 1 or 2 steps forward. Now let's come to some of the things. And another thing what changed in pediatric cataract surgery was the way we started giving our general anesthesia. First, as soon as we started in last year May, our anesthetists became very panicky about giving general anesthesia due to risk of aerosols. So this is a box which we ordered, and it came in 3 different sizes. So during intubation, the child was kept under this box. The OT doors were kept open. A fan was kept on the door, moving the OT air outside, and that gave her a confidence. And then we restarted the surgery, and then the cases started pouring in. And another important was COVID testing before general anesthesia. That is another important point we had to take care of. And luckily, we have been doing for last 1.5 years, and till now, no infection to the OT staff has been there. Now, this was a case in which initial corneal repair was done, and then the patient got trapped in the lockdown, and for months was lost to follow up. And what you see, all loose cornea and sutures, and that has led to panners. All blood vessels have come inside the cornea, and especially in this area, on careful examination, there were blood vessels in the cornea. So what I did, we did a peritomy, and the feeder blood vessels we cauterized there, hoping that later on the spanners will shrink and not lead to further damage. And then the cataract surgery was done, and as you can see, there is the intracameral dilating agent has been given. Now you have got a decent size dilatation. Capsulorhexis is done, and in traumatic cataracts we have to be careful because of poor visualization. Many times we are not able to do proper capsulorhexis, but luckily in this case we were able to achieve. Another thing is that in long-standing cataracts is the fibrosis of the anterior capsule. That is another problem we face. And as you can see here, we avoided the fibrosed area and when completed the rexes. And then the cortical aspiration is done. And IOL implanted in the bag. And after this has been done, we do vitrectomy access for posterior capsulotomy in all of our cases. And if visualization is poor, it is much more easier to do. And advantage is that all the lens, all the IOL is in the bag if we are doing this procedure. And finally, the ports were hydrated. So we go to the next situation. This is another case in which the child had trauma and came to us months later. And by this time, it was a blunt trauma. The anterior capsule has got fibrosed. So initial capsulorhexis was attempted. And as you can see, you can go only till one point. Beyond that, the capsulorhexis will not progress. But in children, we have to aim for IOL implantation in the bag. So what we did, we stopped at the point where it touched the fibrosed area and then went in with a cutter. And with the cutter, the fibrosed area cuts quite well. And with the high speed 23 gauge vitrectomy cutter, the capsule can capsulorhexis vitrector assisted capsulorhexis can be very smooth. And as you can see, even in the non-fibrosed area, we have used the cutter to enlarge the rhexis size. And at the end, it will be a good round rhexis only. And with the one thing we have to be careful while implanting the IOL, it should not stretch the rhexis margin too much because chances of extension will be there. And very trimming the fibrosed area, and now we get almost a 5 millimeter or 5.5 millimeter size rhexis. The cortical aspiration was done, and good visual access, red glow is there, as you can see now. IOL implanted in the bag. And over the years, I've switched mainly to 3-piece IOL in children because, again, this IOL over the years, maybe 10 years, 15 years down the line also, it will be as clear as it is now. So this has become my first choice of IOL in children. And this is what you see at the end of the surgery. Now coming to the next thing, this was a child again after the initial surgery lost. And as you can see, the main port was suturing that got all inflamed. The anterior segment inflammation led to pupil get obliterating. And these are the cases which eventually end up with a very dense amblyopia. But again, we have to salvage the situation at this stage also. And initially, we tried using the cutter to make a good size pupil. But again, it is sucking but not cutting very well. And then we use Sinsky hook, and now you can see the visual axis is more or less formed and clear. And these are the main problems as a pediatric ophthalmologist what we faced in children. And the resurgery rate increased because they were not following up properly with us. And now you can see a very good decent size axis, and visual axis is generally clear, so we need not do anything. 6:30. More importantly, these strands from the iris have to be removed because again this will lead to posterior synechia, and then again the pupil may get obliterated. So that is why we try to remove those strands. And again you can see iris, pigmented iris tissue here. So if you remove all these, chances of again recurrent inflammation will be much less. And this is the end of the procedure. Thank you, Dr. Satyajit. Thank you so much for giving me this opportunity.